All right, Dr. Wayne.
Okay, hi everyone. We're just at 7:30, so we'll get started. For those who don't know me, I'm James Wang. I'm the medical director of the Swedish Neurohospitalist team. And for today's Neurohospitalist hosted Grand Rounds, it's my pleasure to introduce our very own Dr. Sue Kwon. Dr. Kwon graduated from Yonsei University Medical School in South Korea. She completed her neurology residency training at the University of Cincinnati, and she completed her vascular neurology fellowship training at Stanford University. After fellowship training, she joined the faculty as an assistant professor at the University of Alabama at Birmingham for 4 years before joining us here at Swedish in the stroke clinic and as a neurohospitalist. Today, her grand rounds topic is perfusion, imaging, and stroke. Everyone, please join me in welcoming Dr. Sue Kwon.
Hello, thank you for the introduction, James. And it's my pleasure today to talk about perfusion, imaging, and stroke. So let me share my screen. All right, James, can you confirm that you are seeing my slide?
Yes, I can see your screen.
Okay, perfect. All right. Thank you everyone for joining us today early in the morning. Today I'm going to talk about perfusion, imaging, and stroke, which has been a real paradigm shift in acute stroke care. If you have any questions during the talk, feel free to put them in the chat, and then I'll get to them at the end of the talk. I'll just pause for 10-15 seconds and let some more people come in. I think people are starting to join us. Okay, I will slowly get started. Again, if you have questions, put them in the chat and I'll get to them at the end of the talk. I have no financial disclosure or conflict of interest. And today's objectives are to understand the technology behind perfusion imaging and to review the clinical application of perfusion imaging in stroke, to recognize pitfalls and limitations of perfusion imaging, and to explore future uses of perfusion imaging. A paradigm shift. So you're all probably familiar with the concept that time is brain. So every minute lost is brain lost. And because time is brain, we have based all of our acute stroke treatments on time. So you've heard of the 4.5-hour window for TPA, et cetera. And once you're outside of a preset time window, you're no longer eligible for treatment. But we started to wonder, is the speed of brain cell death the same for everyone? So if 2 million brain cells die every minute, then stroke outcomes should directly correlate with time passed since onset, and most people would have a very predictable infarct course. But as our knowledge of stroke grew, we realized that not all brains respond to ischemia in the same way. And researchers found that different brains infarct at different rates, and the range was highly variable. So as low as a couple thousand cells per minute to several million cells per minute. And so the concept of fast versus slow progressors of infarct became more apparent. And physiologic studies show that there were specific thresholds for reduction of blood flow that caused reversible silencing and irreversible cellular depolarization or infarct. And subsequent studies demonstrated that evolution of penumbra to infarction is a dynamic process, and it depends on duration of arterial occlusion, and it's counterbalanced by collateral blood flow, and everybody is a little bit different in how they infarct their tissue. So there's very significant inter-individual variability. And so the question became, how can we parse out the slow infarctors from the fast infarctors? How can we identify those people who have salvageable penumbra at different times and treat them safely? And of course, safety is a big issue because with a treatment like alteplase or tenecteplase, the risk of bleeding goes up significantly with time. And it's such a significant risk. So the benefit of the treatment is limited to a short window. But with the advancement of endovascular therapy and simultaneously with the development of perfusion imaging, we were able to expand the selection of patients that would benefit from treatment. So a new era of acute stroke treatment dawned. Rather than time-based treatment, we can focus on tissue-based treatment. So there is salvageable tissue left to save and not just time within the time window. This should dictate treatment decision. This opened the door to extended window treatments, and it was made possible by perfusion imaging. So we're going to delve into perfusion imaging today. Now remember, time is still very important in acute stroke management, so don't slow down, but we can tailor our treatments a little bit better now. Okay, so let's take a look at perfusion imaging. What is perfusion imaging? It's an imaging modality that shows how blood flows through certain areas of the brain. There's lots of different types of perfusion imaging, including SPECT, PET, CT, and MRI. In acute stroke, we want fast, non-invasive, and highly sensitive imaging. And so CT is the most commonly used type of perfusion imaging, followed by MRI perfusion in institutions where we can get stat MRIs. And I will focus on CT perfusion imaging mostly for this talk because it's just the most commonly used type of perfusion imaging. But the concept of perfusion imaging is similar for different types. It's a temporal sequence of imaging, meaning that slices of brain images are repeated multiple times after injection of contrast. And over time, the increased parenchymal attenuation will be linearly proportional to the contrast concentration. Then as the contrast washes out, the attenuation will decrease. And so for each pixel on a CTP map, hemodynamic parameters like blood flow and blood volume are calculated based on the time density curves created from the wash-in and wash-out of contrast material in the pixel. And so on this graph, the x-axis is time and y-axis is contrast enhancement. And we can calculate the cerebral blood volume by taking the area under the curve. We can calculate the cerebral blood flow by taking the maximum slope of the curve. The mean transit time, or MT, is the mean time it takes to reverse specific brain tissue. And your time to peak is time it takes for the contrast to reach the maximum concentration. The key components of CTP are as follows. Cerebral blood volume, which is volume of blood within a voxel of brain, or basically milliliters of blood inside blood vessels per 100 grams of brain tissue. Cerebral blood flow, or CBF, is volume of blood flowing in a unit of brain mass during a unit of time. So it's basically CBV per minute. And of note, normal gray matter has higher CBF compared to normal white matter by 2 to 4 times. And mean transit time, or MTT, is average time required for contrast bolus to traverse the voxel in seconds. And typically the MTT for normal tissue is about 4 to 5 seconds. And time to maximum, or Tmax, is time from start of the scan until maximum intensity of contrast bolus that arrives at each voxel in seconds. So what CTP means at the tissue level is that if the CBV or CBF drops beyond a certain level, that signifies irreversibly infarcted tissue. And delayed transit time and time to max, Tmax, signifies ischemic areas that may still retain reversibility. So CBV or CBF is used to show infarct or core, and Tmax or MTT is used to show penumbra. And depending on which software you use, some softwares use CBV, some use CBF. There's a little bit of controversy on whether CBV is better or CBF is better in indicating core infarct. I think most automated softwares use CBF. So this is an example of ischemia and infarct. So reversible versus irreversible damage. In an area affected by ischemia that's still reversible, the MTT and Tmax are increased, meaning that it takes longer for the blood to arrive in this area. And in the penumbra, the CBF is slightly decreased, but it's still above the threshold for cell death. And the CBF can be slightly decreased or normal or even slightly increased due to dilation of blood vessels. And then if you look on the right side, when the CBF drops significantly to below the threshold for cell death, so below 30% of normal, that results in core infarct, and that's irreversible damage. And we can map that out on perfusion imaging. And so the concept of perfusion is pretty easy, core versus penumbra. Concept is easy enough, but to be able to compare between patients and select individuals for treatment, especially based on research studies, we need established numeric thresholds. And we need to be able to calculate the volumes quickly. And so automated processing softwares were developed to help us with that. And there's various different types. Rapid is very commonly used, and there's other automated softwares as well. And even with the use of fully automated software, clinicians do need to understand the concept, and there is a bit of a learning curve in order to interpret the data accurately. And so that's why we're having this talk, so we can interpret it adequately. And like I said at the beginning of the talk, I have no financial ties, I have no disclosures. I have no investment in Rapid, but this Rapid is the most commonly used software, so I'm going to go over it briefly. I think it's a great example just to look at to see how we interpret perfusion imaging. So this is called the comprehensive mismatch map. It's the main summary page of the CTP. It's like the first page that pops up when you open the CTP images. And simply put, pink is the core and green is the penumbra. When the CBF decreases to less than 30% of normal, that is used as the cutoff for irreversibly damaged tissue. And the area that has delayed arrival of contrast of more than 6 seconds is the penumbra, shown here in green. And so the green area is area that's still holding on, but it is likely to progress to infarction. So this is tissue at risk. And if no reperfusion is achieved, this will be the final infarct volume. But at the moment that this imaging is obtained, the pink area is presumed to be the infarcted tissue at that moment. And so if you look down here, the mismatch volume is basically the difference between the pink and the green, the difference between core and penumbra, which signifies potentially salvageable tissue. And the next page of RAPID is the 4-threshold Tmax map, and it can identify mild to severe delays in arrival of contrast. So the red region is the area with more than 10 seconds of delay. So this area likely has poor collateral flow and is associated with more rapid infarct growth. The blue and the green region, the Tmax delay is mild. So this is an area that is slowly progressing to infarct. The blue area may not progress to infarct at all if the collaterals pick up. The next pages show different thresholds of CBF and CBV reductions. So if you look down here, you can see CBF below 20% of normal, CBF below 30% of normal, 34%, 38%. And then this is CBV below 34%, below 38%, 42%. And so you can see different degrees of reductions. This vertically long page is called rapid image columns. And from left to right, there is the baseline non-contrast CT on this page. This is very helpful because we can very quickly see if there's any hemorrhage, any obvious hypodensity, any old encephalomalacias that might confound the perfusion image. And so it's nice to have this non-con CT here. And then to the right is relative CBV, relative CBF, mean transit time, and Tmax. This is a qualitative view with no thresholds applied. So no volumes are calculated based on a certain threshold. It just shows you the quality of the perfusion. And sometimes subtle differences that don't reach the threshold cutoff can be seen here. So this can give you a lot of additional information and can be very useful. For example, on this, I don't know, yeah, I think you can see it on the very right, the Tmax column. You can see the asymmetry in the Tmax, and I don't think in the yeah, you can see some asymmetry in the CBF and CBV as well. So the CBV and CBF might not have reached a threshold on the summary map, but you could see the qualitative images here. The AIF and VOF locations map allows you to see where the software identified the AIF, or the arterial input function, and the VOF, the venous output function. So basically the software finds a vessel that shows early arrival of contrast bolus, and it assigns it as the AIF, and it kind of basically puts a dot on it and says this is normal arterial, this is a normal artery that has contrast coming in. And then it assigns the VOF, the venous outflow function, when it finds a venous sinus, and it identifies it with a blue dot. And so you can see, if you look carefully, you can see the red dot here in an artery, and then the blue dot here in the venous sinus. And the location of AIF and VOF can be manually changed if you find that the software assigned either one inaccurately. You can put it manually on an artery or a vein. The movement map shows patient movement or degree of the target's rotation in the X, Y, and Z axis. And this is important because patient movement can cause artifacts. So we need to know if and when and how much the patient moved, so we can see if the CTP is trustworthy. We can also manually cut out portions of the time to improve accuracy of the CTP. And then the arterial input and venous output curves. This is very important as well. The software needs to identify blood flow going in and out of a normal vessel in order to show relative abnormal areas. And so when the contrast traverses through the vessel appropriately, the red curve, the arterial input curve, should precede the blue curve. They both should have a clear, sharp peak, and both curves should fall to a decent plateau afterwards. So if the curves are out of whack, you know that the perfusion images are unreliable. Okay, so enough about the technical parts of perfusion imaging. Let's talk about the clinical application of perfusion imaging. It helps us select patients for thrombectomy. Thrombectomy patient selection is the most celebrated ability that perfusion imaging has proven itself for. Just an important reminder that within 6 hours of onset or last normal time, there's no need for perfusion imaging. Guidelines recommend that once a large vessel occlusion is established and you have corresponding symptoms, just go for it. Consider the patient for thrombectomy. You don't necessarily need perfusion imaging. It's beyond 6 hours when you can really reap the benefits of perfusion imaging. And this was proven by the extended time window trials, Dawn and Diffuse 3. So these trials tested the safety and efficacy of thrombectomy beyond 6 hours with the aid of perfusion imaging. So Dawn selected patients with disabling deficits and small core volumes to ensure that patients who will get the most benefit from thrombectomy are selected. And Diffuse 3 selected patients with an infarct core smaller than 70 mLs, mismatch ratio greater than 1.8, and mismatch volume greater than 15 mLs. And Diffuse 3 actually ended early due to a clear benefit. So now we know there is a clear benefit. And looking at some of the major thrombectomy trials and comparing those that used perfusion imaging versus those that didn't use perfusion imaging for patient selection, all the trials showed benefit with thrombectomy treatment in carefully selected patients. And those that used perfusion imaging for patient selection had the greatest absolute benefit. Another great use for perfusion imaging is outcome prognostication. So looking at CTPs or perfusion imaging, we expect that the final infarct volume would correlate with the baseline core lesion if successful reperfusion is achieved quickly. And we expect that the final infarct volume would correlate with the with the penumbra, the green, if you will, if reperfusion is not attempted or unsuccessful. And that's exactly what they found in studies. So perfusion imaging, if you take into account the reperfusion outcome, so it predicts quite active. So up here, this is an example of fast and slow reperfusion. And you can see that the baseline calculated core and the final infarct volume correlate quite well after successful reperfusion. And then B is an example of unsuccessful reperfusion. You can see that the penumbra, the green, correlates better with the final infarct volume rather than the initial core. And in this study, their multivariate model demonstrated that parenchymal hemorrhage and endovascular reperfusion results were the variables significantly associated with accuracy of infarct prediction using perfusion imaging. How about detection of stroke? Can we use perfusion imaging for that? So perfusion imaging is not used for the purpose of diagnosing a stroke, but often we have cases where the CTP helps in ruling in or ruling out a stroke. It should not be the final, it should not dictate whether we rule in or out, but it can give you a pretty good idea sometimes. The sensitivity and specificity for diagnosing a stroke using CTP is adequate for an acute phase test. But very importantly, we need to remember that small infarcts, and especially lacunar infarcts, will not show up on CTP. And there's other false negatives and false positives as well. So you should not use CTP to rule out a stroke. But in a lot of cases, it does give you a pretty good idea. So this is an example of a small infarct that we were lucky enough to see on the CTP, and it helped us with the acute management of this patient. Again, we cannot rule out a stroke using perfusion imaging. I found CTP to be very useful in finding the culprit vessel involved in a stroke. So just looking at the CTP without even looking at the angiogram, we can see that in this case, the right PCA territory is involved. Here we can see that the left ACA territory is involved. So you can look at this first and then go looking for a vessel occlusion on the CTA, especially if it's a small artery. It can help you find the culprit vessel. This is a case where the patient presented with sudden right side weakness and confusion, and CTA showed a right MCA occlusion, and we were all scratching our heads. Right hemisphere, right MCA occlusion and right side weakness? That doesn't seem right. And then the CTP showed this, and so we found out that the right MCA occlusion is a chronic finding. The actual culprit vessel for the right side weakness was a left MCA branch occlusion. I've found that perfusion imaging can help in identifying the etiology of stroke sometimes. It can give valuable information about symptomatic vessel stenosis, sometimes determining if an embolic event occurred, and sometimes even finding Moya-Moya cases. This patient presented with fluctuating aphasia and right side weakness that was worse when standing. And when the patient had this CTP done, the patient was actually asymptomatic, laying in the scanner, normal speech, no weakness. And the summary map looked normal. The automated software said 0, 0, everything looks good. But if you look on the qualitative map, you can detect a slight asymmetry of the Tmax in the left hemisphere. If you look on this very right column in the left hemisphere or right side of the screen, you can see that the Tmax is slightly increased. And then we went looking at the CTA, and the patient was found to have a significant stenosis of the left carotid artery. So this was basically symptomatic carotid stenosis causing TIA symptoms. This patient ended up having a very, very small stroke that almost looked like a lacunar stroke or small vessel type of stroke. But when we looked at the perfusion scan, it showed a different story where there was evidence of an MCA branch occlusion. And so we were able to tailor the stroke evaluation and keep looking for an embolic source. This was a young patient found in bed attended, no cardiac history, but the patient did have a history of prior strokes. And on the perfusion scan, we saw bilateral decreased perfusion, and it turned out that this patient had Moya-Moya syndrome. You can even see a hint of that on perfusion scans. Another fun use of perfusion is for recognition of stroke mimics, including functional neurological disorder, migraine, seizure, global hypoperfusion. Few things are more satisfying than seeing a nice, clean, normal perfusion scan in a stroke code when you suspect that the patient is mimicking a stroke. Again, remember that CTPs cannot rule out a stroke, so you should not just look at this and say, oh, you're not having stroke. But it does give you a lot of reassurance, especially when the patient comes in with inability to talk and florid, one-sided weakness and gaze deviation, etc. And you see this perfusion scan, it gives you some reassurance that at least the patient is not having a large vessel occlusion. Migraines can cause perfusion abnormalities. The perfusion can increase or decrease depending on which phase of the migraine you're in. So they say during the aura phase, when you're having some neurological dysfunction, the perfusion might be decreased during that time. And then when you're having the pain, the throbbing phase, that's when the perfusion might be increased. And a hint can be perfusion abnormality that doesn't follow a vascular territory. So it's not clearly in an MCA or ACA or PCA territory. It's kind of over the entire hemisphere or kind of traverses different territories. That can be a hint that it's not a vascular occlusion, but could be migraine. During a seizure, CBV and CBF can be increased, and the MTT and TTP, or time to max, can be decreased. So in this example, you can see in the left hemisphere, the CBV and CBF are increased, and MTT and TTP are decreased. So the blood is rushing there quickly, and there is more flow on the side that is seizing. And then in this case, surely this must be artifact where the whole brain is not getting good blood flow. There is delay in blood flow. But you look at the motion map, and eerily, there is no motion artifact at all. And the contrast bolus curves look adequate too. And turns out this patient was in cardiac arrest while the CTP was being done. Pitfalls and limitations of perfusion imaging. There are quite a few. So technical pitfalls. These are some images that I captured during fellowship. This is a pig face artifact, and this is a Terminator artifact. So you can have artifacts on the images, from the eyeballs, the skull base, the bone interference. You can get lots of different artifacts. Movement can definitely throw you off. Poor contrast bolus timing, inaccurate AIF or VOF selection. Again, you can manually change that if needed. Inadequate brain coverage area. And notoriously, the posterior circulation is not well represented by perfusion imaging. Most of the times, artifacts will be self-evident, and the software will tell you that the image is not trustworthy. This is an example of inadequate brain coverage, where you just have a bunch of spinal cord images and the top half of the brain is missing. And although perfusion imaging can help you identify stroke mimics, it can also fool you into thinking that the mimic is a stroke. You can have hypoperfusion due to reversible vasospasm or chronic infarcts, or in the postictal phase of epilepsy, and you could mistake those for ischemia or infarct. You can get hyperperfusion due to reperfusion phenomena, and this can actually mask an acute or subacute infarct. And then, of course, small strokes, posterior fossa strokes, those are often negative on perfusion imaging. So you need to watch out for those. And then from a clinician standpoint, over-reliance on perfusion imaging can lead you to make erroneous decisions. The timing can influence the accuracy of CTP. So when the onset or last normal time is unknown, or if you're in a very hyperacute or a very delayed time period, you need to interpret the CTP carefully. And numbers can lie, obviously, and of course you need to treat the patient and not the imaging. And sometimes CTP is just plain unnecessary. So we need to try to not over-rely on perfusion imaging and just use it for our benefit. There's an issue called hyperacute inaccuracy, where the sensitivity and specificity of the infarct thresholds are lower in the golden hour, the first hour after stroke onset. And the plausible explanation is that CTP measures blood flow rather than the actual neuronal function. We just kind of assume the neuronal function based on the flow. And so very early in this ischemic cascade, the flow change is occurring dynamically. And so the survival threshold is more heterogeneous. And so just measuring the flow might give us false results. And so the general rule is that in the very, very early window, within 6 hours, and especially within the first hour, one should not set a core volume threshold to withhold treatment. And that's why guidelines say you don't need perfusion imaging within the first 6 hours, because it can be less accurate. And during fellowship, I had a perfect example of a hyperacute case. This patient basically had a right MCA stroke while in the MRI scanner. He was getting the MRI to evaluate a TIA episode and was in the scanner. And then the technician picked up that the patient was kind of grunting and behaving strangely, and asked the patient questions. And then they noticed that the patient definitely looked abnormal, and so they called the fellow, and we obtained an MR perfusion during the scan, and this was what we saw. Now, full disclosure, this was at an academic center. I was obsessed with perfusion imaging, and so this was for a purely academic purpose. A perfusion scan would not be clinically indicated in this case, and if the patient is having a stroke while in the MRI scanner. But we got the perfusion imaging, and this is what we saw. And of course, we pulled it out immediately, and we treated him appropriately. We actually proceeded with a thrombectomy. Despite this perfusion image, because we felt that surely he could not have infarcted, irreversibly damaged all of this tissue within minutes of vessel occlusion. And surely his final infarct did not look anything like this core on this perfusion map, proving the point that hyperacute perfusion images can be drastically inaccurate. There's also the issue of subacute inaccuracy, where if you are beyond a few days after onset of stroke, then the CTP becomes unreliable again. There's a phenomena called fogging, where the non-contrast normalizes after showing hypodensity in an infarcted area. So this occurs many hours, usually a few days after onset. And CTP at the time that this fogging occurred demonstrated that there was elevated CBV and CBF in the infarcted area. And so this supports luxury perfusion or hyperperfusion as the mechanism to explain fogging. So we need to be aware that CTP can be misleading when this happens. And typically software algorithms would depict luxury perfusion as hyperperfusion on the infarcted side. But here, the automated software considered the luxury perfusion of the left hemisphere, the infarcted side, the left hemisphere, as a normal reference. And then they marked the unaffected right hemisphere as infarct or as ischemia with a little bit of core in the middle. And so if you look at just the perfusion prognostic maps in isolation, it can mischaracterize the laterality of ischemia even. All right, so the last part of my talk is looking at future uses of perfusion imaging. So perfusion imaging can help extend the use of IV thrombolytics beyond the 4.5-hour potentially. And this is similar in the goal of extending the treatment window to the Wake Up trial, if you're aware of that, where they used MRI, DWI, and flare mismatch to select patients for thrombolysis. And so far, there's 3 trials looking at whether perfusion imaging can identify patients with salvageable tissue beyond the 4.5-hour window. There was Extend, ECAS4, and EPIPET. And on meta-analysis of these trials, they found that those treated with alteplase achieved a better functional outcome despite having a higher rate of hemorrhagic transformation. Timeless is an ongoing study right now looking at tenecteplase versus placebo in patients with a perfusion mismatch in the 4.5 to 24-hour window. They're continuing to enroll, and we are eagerly awaiting the results. In clinical practice, a lot of these patients would simultaneously be eligible for thrombectomy. And in many cases, will go straight to thrombectomy, bypassing the thrombolysis step, the IV thrombolysis step. But I think in the near future, you will still end up seeing these cases alongside Wake Up protocol cases, where we shatter the old time window and truly change our practice to tissue-based treatment models. And future stroke treatment trials will continue to push the boundaries of thrombectomy eligibility as well. So there's an interest in looking at the large core, large mismatch patients who have larger baseline infarct cores than those used in the Dawn and Diffuse 3 criterias, but who may still have a lot of salvageable tissue left to save. So people want to see, are those people eligible for thrombectomy? Can they safely be treated? And then there's also an interest in expanding the time window even further, because when they looked at some of the diffuse 3 data, they found that a good proportion of patients still had persistent favorable profiles greater than 38 hours after the last normal time. Another great potential use of perfusion imaging would be to improve the triage for transfer decisions. So for centers that are not capable of performing thrombectomies, they can opt to transfer all potential LVO cases, which would be a lot, and it could overwhelm the transfer system, and it can really bog down thrombectomy capable centers. They can obtain perfusion imaging and transfer only patients who can be a thrombectomy candidate at the time of their assessment. Now we know that things can change a lot by the time the patient arrives at the thrombectomy center, and a lot of these patients end up not being eligible by the time they arrive. And so transfers can be further selective, perhaps using perfusion imaging, using the hypoperfusion intensity ratio. And this is something that can be calculated off of the perfusion image. So the HIR, the hypoperfusion intensity ratio, is the ratio of the area with greater than 10-second delay in Tmax to that greater than 6-second Tmax. So if the ratio is high, then the penumbra is likely to progress into infarct quickly. Like this example down below here, the HIR is 0.8. And so the area with very delayed contrast arrival, it takes up a big part of the penumbra. And so this patient will probably go on to infarct this red territory very quickly. Whereas if the ratio is low, like in this example up here, the HIR is 0 or 0 point something, 0.00 something. So they are more likely to be a very slow infarctor and kind of hang on until they are transferred and go for thrombectomy. Now, we're still establishing the cutoff values for HIR, and they still need to establish that this is reliable. So it's not, I don't think we are using this in isolation to triage or select patients for transfers, but this is something that we could look at. And then lastly, no talk about the future can leave out artificial intelligence, right? So artificial intelligence can be applied to perfusion imaging. Current tissue fate prediction models use what they call a generalized linear model. So we're kind of linear in predicting stroke outcomes. But unlike these models, artificial neural network or artificial intelligence holds no linear assumptions, and so they can basically interpret a lot of data in a more dynamic, simultaneous manner, and basically give you more accurate results. They can take into account different data points for a better prediction. So that is all that I have prepared today. These are the references. Thank you so much for listening. Let me see here. Stop share. Okay. And let me see if there's any questions. Okay, how do the other imaging software packages compute these variables, or do they use other algorithms for measuring? When it comes to using either CBV or CBF to calculate the core volume, and then using the time variables, either Tmax or mean transit time, some sort of the time variable to calculate the penumbra. That is a common thing among the automated softwares, but the exact algorithm of how they calculate those and whether they take both of those parameters or one or the other might be different. But the basic concept is the same using CBV or CBF and Tmax or mean transit time. Oh, I'm sorry, there was somebody who said I can't hear. Were you able to hear my talk?
No, we could hear your talk. I
Okay.
could hear your talk just fine.
Okay. I didn't spend a whole hour talking to myself.
Yeah, Sue, that was a really good talk. Thanks for giving a great explanation of a complicated topic.
I think we have one more in the chat. Great talk, thank you. Just a comment, when we have had a few surgical epilepsy cases where outcomes were not as hoped. As diagnostic tools have evolved, we can see worse outcomes when we fail to carefully screen vascular flows into the localized zone of epileptogenesis. Understanding if flows are decreased permits trial of antiplatelet or other thinner, and sometimes makes a huge difference in seizure control. The other side of a perfusion mismatch opens doors to consider revascularization instead of tissue resection. Great, thank you for the comment.
Okay, great. Does anyone else have any other questions? I don't think I have any other particular questions. It was good talk.
You finally get what all those extra images are in the perfusion packs, other than the summary slide. Okay, great.
I guess I have one question. You mentioned in the talk about using CT perfusion for the extended window for thrombolysis. I know some centers are doing that, but most I think are not. I know you had Timeless as a trial that's ongoing, but do you have an opinion on using CT perfusion currently for extended window thrombolysis?
I think when we have the results of Timeless, we can probably parse out a little bit of how thrombectomy plays a part, because the majority of people who have a perfusion mismatch have large vessel occlusions. And if they're in the extended time window, when they're beyond 4.5 hours, they usually go straight to thrombectomy. But in patients where the patient is at a non-thrombectomy center, but they're able to get perfusion imaging and they're kind of in transit to be transferred, I think those might be patients who could be a good candidate for thrombolysis in the meantime. I think the data that we have right now, the meta-analysis that I showed you, those are based on some of the older trials, and those patients at that time probably did not have thrombectomy as a mainstream treatment modality. So it was in a slightly different era. So we may not be able to extrapolate that data directly to our clinical practice right now. So I think we're waiting for the Timeless results before fully embracing using solely perfusion imaging for extended thrombolysis.
Okay, great, thank you. And there's one more question in the chat. Someone asked, what is the role of perfusion imaging in Moyamoya disease versus catheter angiogram?
I think it gives you different information. So the perfusion imaging will show you how the brain tissue is reacting to the stenosis of the vessels, whereas the catheter angiogram shows you directly how the vessels look. And yeah, the catheter angiogram can give you a little bit of data on the perfusion of the tissue as well when you look at the delayed phases, I guess. But I think it gives you slightly different information. So depending on what data you're looking for, you may need to get both. I don't think the perfusion can help you avoid getting an angiogram in a case where you think the patient has moyamoya.
Okay, great. I don't think there's any other questions. Thanks again, Sue. Really appreciate your time and effort on the talk. Thank you everyone for attending.
Thank you
Thank
very
you.
much. Have a wonderful day.
Bye.
Bye.